Hello and welcome to Value-Based Healthcast. It's on the 6th of December. Got an exciting program. So value in health is how do we reach more people, making it accessible but for the same envelope of funding, seeking the best outcomes. Today we have Adele and Sarah joining us, and hopefully Phil Thomas later. But before that, just a quick introduction of who we are. So I'm Nick Wilkinson. I'm a paediatrician based here in the University Hospital of Wales.
And I'm David Hanna, another paediatrician, also based in Cardiff, with an interest in value and service transformation.
So so you've not joined us for a couple of times.
No,
how's it going?
I've been absent. Yeah, good, thanks. Yeah, a nice sort of autumn coming into winter now, so things are good. A little bit disappointed tonight because the Lanish and Christmas lights have been cancelled.
Oh no.
So won't be going to get my hot chocolate mince pie and meet Santa in Lanishan Village tonight, but that's what Storm Dara is bringing to us. How about you, Nick?
Well, I just hope I can get home on the trains. You know, there are not too many leaves on the track. And in fact, if we can get out of the hospital because of the quademic, you know, so COVID, norovirus, RSV, flu, it's all happening. Yeah. And surges. Is that affecting you much in the A&E?
Massively. Yeah, it's a big issue. Flow into the hospital, out of the hospital is a big issue at the moment. So everybody working very hard to try and keep the wheels on the wheels turning, really. Yeah.
So today, you know, it was about this time last year, the Welsh Value and Health Centre was asked to provide its expertise, advice, knowledge in supporting the national clinical networks to adopt value metrics when designing new pathways. So the focus has been on 5 high value, high impact pathways in diabetes, hip, knees, bone health and heart failure. And we talked about bone health last time. Next year could be more developed, but what we want to do is just sort of bring some of those discussions together. And we're very lucky to have Adele Cahill, Sarah Puntoni, and hopefully Phil Thomas, who's a consultant orthopedic surgeon. He's actually operating at the moment, but will hopefully join us in between theatre sessions.
Yes, so welcome to Adele and Sarah. So Adele is was deputy director for Welsh Value and Health Centre, and now is a deputy director for value in the DDTIV director. I'm going to let you explain to us, Adele, what exactly that is and what your current role is. But ultimately, that's to do with value-based transformation through digital data, technology, and innovation. And Adele's been leading on the high impact, high value pathway work.
And then Sarah Puntoni, who I've been very lucky to work with. Sarah was one of the original team members of the National Value in Health programme from its inception, joining in 2019. Sarah's led on the development and delivery of national value-based programmes and has played a key role in working alongside clinicians engaging with health boards in the development of these high impact pathways. Just to quickly let you know a bit more about Phil, he specialises in paediatric and adult hip disorders. Phil has worked alongside the National Value team for a few years and is heavily involved in PROMs, so patient-related outcome measures. And hopefully he will join us shortly.
Right. So how these sessions work is generally we listen to some experts and some clinicians, managers, nurses, people from across the spectrum in health, sharing with us their experience of working in value-related projects and value-related work. And we'll hear from Adele and Sarah shortly. We'd really encourage you to ask questions of the panel, and you can do that using the chat bar in the talk. And we will then field these to Adele, Sarah, and Phil throughout the session.
Okay,
yeah, so without further ado, then we'll hand over to Adele and Sarah.
Oh, lovely. Thanks both. Well, I can't promise that Sarah and I is going to be as funny as Nick and Dave. They obviously come through as a twosome. They've been working together for some time and get each other's jokes. So I can't promise that, but I can promise
Maybe a
you
couple of
that,
Muppets. I don't know.
So just to add a little bit to what they said in terms of who I am. So I am currently the Deputy Director for Value in DTIV, and I'll share a little bit about DTIV in a second, but been in the value-based healthcare space now for over 10 years. And prior to that, was a procurement professional, old dinosaur in the NHS, 41 years this year. So been around the block quite a while. Sarah will introduce a little bit more about herself when I hand over to her, but we just slides. There you go. Just sharing the slides. Let me know when you can see them. Somebody give me a thumbs up when it comes through. Yeah, is it through? Ah, okay. So I don't see them then. Okay.
You're going to hit slideshow.
Ah, I see. Okay. So can you see the slides okay?
We can see the slides.
You
We
can,
might
okay.
just need a second to share them.
Yeah, all good.
All good? Okay, excellent. So as we just mentioned, we are from the Welsh Value and Health Centre, which is part of the wider DTIV Directorate. The Directorate came together in April 2024 and was formed as part of the transition over into the NHS Executive. And as you can see on the slide, we are calling ourselves Value-Based Transformation unlocked really through enablers such as digital data, technology and innovation. And today we're going to share a little bit around how we have developed a methodology to look at high value, high impact interventions in order to create optimum pathways across a range of clinical areas. I'm assuming it's moving okay?
Good, thank you.
Brilliant. Okay. So the content for today, we're going to look at what were the drivers, really? How did we get into this space of looking at these optimum pathways? Sarah's going to talk to you around some of the methodology that we've applied and how, using her skills around engagement with clinical leads and other teams, we've been able to come to an agreement around what that pathway looks like, and in particular, what data we will be collecting to evidence value. And hopefully, if Phil gets to join us, we will hear from him around what's his perspective of working with us as a team in this way, and also with his wider colleagues across the networks. So just a little bit around the drivers. Nick in his introduction mentioned that this work came out of the Value and Sustainability Board last October actually. And we were a little bit unsure on how we would start this piece of work. It was recognised that there was significant health challenges across multiple disease pathways, of which the 5 originated. And we've been asked many times, well, how did you prioritise those 5 areas? And it would be untrue of me to say that there was any scientific prioritization process in terms of how we got to these, other than the fact that we had strong clinical engagement in a number of those areas. We had already been working in that space with clinical networks, and they were forming as large, big discussion points throughout Welsh Government. What we do know, though, is that they're all major health issues that impact on the wider system. We know that all of them increase the length of stay in hospitals, utilise significant bed days, and we know across each of these pathways that they aren't equitable and access is really challenging for patients. And therefore, some of the things that we wanted to do was to consider how can we increase the value to patients and the system by providing these optimum pathways. But more importantly, how could we evidence that these pathways were being followed and that we really were delivering value for patients. In addition to that, there had been some discussions around the performance framework, the health boards and organisations are very familiar with completing as returns for Welsh Government. So things like referral to treatment, bed days, length of stay, etc. And our previous director at the time was really cognizant of the fact that none of those performance metrics were looking at value. They weren't looking at improved outcomes for the population that we serve, and was very keen to start to think about how we could include some very specific value metrics into what we called an integrated performance framework. So we've been working with other colleagues within the NHS executive to consider how some of these value metrics, once we start reporting, will find their way into the performance framework and then routinely reported from health boards into Welsh Government. Again, each of the 5 areas and the whole purpose around developing these pathways is clearly evident throughout a number of quality statements that have been written within Welsh Government. The latest one being around bone health that you will have heard Dr. Singh talk about last time, and the recommendations that have come out of that for bone health. And then numerous policy statements that have come out around a Healthier Wales, the Wellbeing Future Generations Act. There's some others specifically around diabetes, cardiovascular, and also orthopedics. And the main thing, I guess, in designing these optimised pathways is not just about making sure that we've got equity and access to patients and that there's a systematic way of working through a pathway, but also to reduce the unwarranted variation that is evident from the work that we've been doing, and to think about what other kinds of interventions could we use through maximising the opportunity we've got now as a new directorate. So how do we use digital technology and innovation across these pathways? And we're not going to go into the detail of each of the pathways today, but if I give you a very small example, that in diabetes as an example, the NICE recommendation suggests that we should be implementing hybrid closed loops for all patients with diabetes type 2. Now, we don't have that across the whole of Wales. We've got pockets within each of the health boards where they have some form of diabetes management, whether that be through something like Freestyle Libre or alternatives. And what this work clearly does is a recommendation out to the health boards to say, as a system, we will work together to make sure that HCL is in place for all organisations. And then lastly, very briefly, and hopefully we'll come back to some of this at the end, is what consideration have we given to the challenges this will face on the wider system? So it's great that nationally we are prescribing what optimum looks like, and we're prescribing what value metrics that we should all be collecting. But that doesn't really take into account the challenges around implementation or providing this data has on each of the health boards and trusts. And we're working very closely with our heads of value, so the value leads across each of the organisations, and the heads of information to understand what these implementation challenges will be. And some early feedback that we've had from some of the teams are, this must be focused, it can't be too wide. So when you talk about diabetes as an example, diabetes is huge. Let's make sure that we are providing focus to the health boards on the things that they can implement, the things they can make a difference to people, and that it's measurable. It has to be meaningful. They're really keen to make sure that whatever metrics we come up with, that they are meaningful to all involved, and that there is a risk sometimes that we can overwhelm organisations with the amount of work that's potentially coming out nationally, and how do they balance that then with local priorities and work that's already scheduled within their IMTPs. So I stop at that point, and I'm going to hand over to Sarah, who's going to talk to you a bit around the methodology that we used, or that we made up along the way, that has now become a tried and tested methodology to you. So Sarah, if I hand over to you.
Thank you, Adele. The slide on your screen is what we refer to as our value pathway. Some of you may have seen it before, as it's been shared in some previous sessions as well. It's meant to be a way of highlighting, if you want, the different stages of a pathway for every patient journey within a disease or condition. We use this as a starting point, so we work very closely with the networks of the 4 clinical areas, particularly with the clinical leads, but obviously with an NDT approach where possible. And the first thing we did is very much starting to look at what are the high impact interventions in each area that we would want to map across each of the blocks, if you want, from prevention to end-of-life care for the clinical areas. And when I talk about high impact interventions, we're very much looking in the short, medium term. So what are the, if you want, the key ingredients that we would want to see across the whole of Wales to be able to make an impact in the short, medium terms on outcomes. And I stress that particularly for things like diabetes, for example. We know that there's a lot more we could do as a society, for example, to stop the rate of diabetes. But as I said, we were very much focused on what we can do right here, right now.
Hi, Sarah. We're just having an issue with your speech and the way it's coming through. It's very broken.
Let me get my headphones.
Sorry about that.
This is good. This is like live TV, isn't it?
And
we've probably got an answer for it somewhere.
And Adele, so I was really interested in the variation, the unwarranted variation, and I'll come back to you on that because I think whether it's variation in process or outcome or value, that variation, the identification of variation is often the start of a conversation, isn't it?
Yes, absolutely. Yeah, it would be good to chat that through.
Sarah, sorry about that. How are you doing?
Well, you'll tell me, is that any better?
Yeah,
much better. Thank you.
Excellent. Sorry, I'm not sure which bit you did come through and which bit didn't. So I'll try and recap very briefly. But the value pathway that is on your screen, those are the areas that we would normally path a disease or a condition from a value lens. So looking from prevention to end-of-life care. The work we've done on the high value measures have been very much driven by that collaboration with the networks and the clinical leads and the MDT approach through the networks again. And the first step we took was very much based on what is on your screen. So it was working with them to identify what are the, if you want, the key ingredients that we will want to see across Wales to be able to make the greatest impact in the short to medium terms on outcomes. And I stress that short to medium terms, particularly in the context of diabetes, because we know that there's a lot we could do as a society to prevent a certain type of diabetes. But obviously the benefits of some of those interventions will take years to actually come to fruition. So we were very much specific around what can we do right here, right now. And as I said, as an approach, we were interested in what are those interventions. And then we started working across all the different blobs, so from prevention to end-of-life care or transition of care. And we identified different elements. And through that process, we also identify where we know that there are best practices. In some cases, we've been working, like Adele was saying, with the networks for some time. So we already had that knowledge. In some cases, it's been part of that process of identifying those high value or high impact interventions. Once we had these agreed as a collaborative approach with the clinical experts, we then start looking at what would we want to measure to be able to then track compliance against those key ingredients of the pathway. And that is where the work becomes a little bit more technical, a little bit trickier. Obviously, you could work in the wish list of things that we would want to measure. And this, if you want, is kind of where we started. So in an ideal world, what we would want to measure. But we also took a pragmatic approach. We know that we have data issues, whether it's because data is not available or because the quality of the data is not accessible or because that data is held somewhere else, for example, in audit or registries. So even though we collect it regularly, the reporting, there's a time lag, and therefore it becomes unusable, if you want, for a service improvement kind of approach. So we marked out a long list of measures, and then we had to work back and forth with our clinical leads to try and identify a short list. We took that process as far as we could between sort of January and March, if you want, to test those measures as much as we could, to try and be realistic about what we could and couldn't do. We took then all of these back to Value and Sustainability Board. And for some clinical areas, that process was very much, if you want, set in stone. So I think for bone health, hip and knees, they were very well defined. We had validated the data. We had clear understanding of the caveats, if you want, about what we would be able to report. For the other two clinical areas, heart failure and diabetes, is a little bit more complicated, it's a little bit more complex, and the data available becomes much more fractured and with much bigger gaps. So we are still working, even to these days, to some degree, to try and improve the way that we can report some of those measures, particularly in those two areas. And I think the great difference between the 2 and 2, if you want, is that access to clinical outcomes data, where we have clinical outcome data, such as in bone health and hip and knee, where we have access to the clinical, the outcomes from the clinical audits and registries. We're able to do much more value measures, the real value measures, to see an impact based on those high impact interventions. In the other areas where we have very limited access, we only realistically can report on activity from secondary care, emergency care. We have some costing data, but it's a very much fractured space with no clinical outcomes data really available to us to report consistently across Wales. Then it becomes much more difficult. So we've since taken on a separate piece of work with the support from the Tackling Diabetes Together programme from Public Health Wales to try and acquire these data sets, so the pediatric diabetes audit and the national diabetic audit, but also the NICOD, the cardiovascular audit as well. So we hope that through the acquisition of those data sets, we'll be able to turn some of the measures that we currently have, which are more qualitative, self-reported from the health boards, around the kind of yes and no kind of questions, rather than more crunchy quantitative data that we would want to perhaps utilize, and we'll be able to switch some of those to, as I said, something a little bit more perhaps value, true value, compared to what we are able to do now. So as I said, in two clinical areas, I think the measures are very solid, very valid, very easy to report. In the other two, there's still a little bit more work to be done, but is already having an impact in the sense that Adele was describing. We're already seeing much more focus across the system, not just from NHS executives and other enabled bodies within the system, focusing on those clinical areas and coming together to look at what support we can put in place to the health boards. But we're also seeing the same in the health boards as well, where actually there is a greater focus of collaboration between different elements of the health boards to come together to look at this pathway as a full pathway of care, rather than perhaps specific block points within a pathway, which I think is a really positive development from this.
Thanks, Sarah.
Thanks, Sarah, and thanks, Adele. So we've got a couple of questions from the audience, which I might come to in a second. But one of the themes I was picking up, Sarah, particularly in your talk, was the difficulty in knowing how well we're doing if it's challenging to get access to value data and outcome data. So how do we know how we're doing if we can't measure how we're doing? And you mentioned about measuring activity, which is easy to do a lot of the time. How many operations, how many patients, how long did it take to do something? Whereas that's not always the outcome that's important to patients. And I remember a similar theme when we met Idris Baker and Anthony Byrne in palliative care. So Idris and Anthony were trying to look at end-of-life care and the last year of life in patients with life-limiting conditions, and looking at the use of palliative care pathways and how difficult they found it to get good data from different parts of the system. So what strategies are in place at a system level to try and get better access to data in all these different silos?
Yeah, I think there's a lot of work across the system, both in the health boards and across the NHS executive, for example. There's work that we within the Welsh Valiant Health Centre have been taken forward around, as I said, the audit acquisition, but also supporting that patient reporter element so that we can match what the clinicians see as quality from an outcome point of view and what the patients see as quality from a point of view, from a patient view. But there's also different pieces of work to try and get some of these data available, particularly in the areas of the system that are less available, such as community and primary care. As you know, that data, it tends to be very hard to come by. And even when it's there, looking particularly at primary care, tends to be aggregated data. So there's still some work to be done from an information governance point of view, but also digital point of view to actually be able to collect and acquire and share that information.
Because the data, so I'm thinking back to the National Clinical Framework, which was written a couple of years ago now, and some of the work done by Alan Wardaw and the team at that point, and the data to knowledge, and I think it was knowledge to practice, and forgive me if I've misquoted there, but they're so important in trying to improve things, and particularly without unwarranted variation. So that would be really interesting to hear about that, and well, it's reassuring to know that work's underway. And is that work underway in the value team, or is that part of the wider functions in the executive?
Yeah, so if I may, Sarah, so I think it is in the NHS executive. There is much discussion going on around how we bring a very clear data strategy together for the executive and all the things that you've just referred to, David, albeit that is being led by the new DTIV Directorate, because that's where the Deputy Director for Data and Analytics sits. I think a couple of points you made there for me is I've been astounded actually around the lack of data that is available easily. I mean, there is lots of data available, but it's in so many different places, in so many different ways that it's written down, that I have, through this work that Sarah's been doing, found it absolutely astounding. And when we talk about scale and pace in the NHS, that for me is one of the things, if we could solve some of the data challenges, then we could get value-based transformation far more quickly out across into the health boards and across the system. The slowness of achieving that data, acquiring it, validating it, cleansing it is so laborious that it does actually hold back major transformation, I believe.
And it's not just that, it's also that sense of risk around data and privacy, and that's obviously a project that I'm working on with you guys that is very much embedded in that, and it's interpreted in different ways, and I've experienced this over 20 years, and so it's how do we embrace that, but then make a quick turnaround rather than just getting stuck at what's interesting is that in the Royal College of Paediatrics, just recently they've announced a blueprint, and one of that is to be less risk averse, and because that will free up so much as to what we do. And I wondered if you had a thought on that.
Yeah, no, it's really interesting, because we know we did an exercise when we were looking at the bone health data and we physically mapped INDA as it happens and his clinical team around what amount of time are they wasting, what productivity do we lose as a result of them having to complete clinical audits and to put information into the system. And I think there is something around, if we can look at a relationship with the clinical audits out there where we receive data automatically back from them and so on, and it's a project Sarah referred to then, that we can actually increase the productivity and release more time to care for some of our clinical colleagues. I think that's absolutely fundamental.
I think as well, though, sometimes we don't appreciate what we have. We do have a lot of data, and sometimes we don't use what we have well enough. We don't surface the data where people like yourself, for example, can make the best decision. And I think sometimes even just surfacing what we have automatically cleans that data by itself and improve the quality, improve sort of, if you want, or reduces the gaps within that data. So I think it's a bit of both. It's going after data that is lacking for whatever reason, but also better use of what we have and cleaning it. And, you know, coding is a major issue at the moment. But again, we need to, as a system, recognize the value that data in itself bring.
I just noticed, you know, Sarah, and I liked your linear approach, but medicine isn't that linear, is it? And we don't have accurate diagnoses, and optimizing intervention depends on the level of need. You know, so it's William Osler who said that medicine is a science of uncertainty and the art of probability. And so we're working on the probability bit with the data, but how do we, you know, you put in accurate diagnosis, but actually most of what I do, they don't fill the diagnosis, but they still have a need. And if we want it to be equitable and we want it to be accessible, then how do we flex around that? Or are we too, am I saying that we're too early in the game? We just got to prove the principle of value. What's your thoughts around managing uncertainty in the system?
It's a tricky one, isn't it? And I think as a clinician, you're probably best placed to really understand the complexity because you live it and breathe it every day. But I think from a personal point of view, it's about being driven by the patients and by that person-centered approach, isn't it? And yes. I think sometimes, particularly in the physical health, more so than, for example, in mental health, we are very much driven by that single condition kind of approach. Mm-hmm. And I think that is probably something that I hope will change going forward, because obviously we have comorbidities to at great levels within our population, and we need to start looking at what are the outcomes as a whole of our population. That's why I think PROMs are so important, because it gives us a different understanding of what really matters to the patient, what really works for the patient. And then when you're looking at aggregated level, you can really start to understand what is the greatest benefit of the intervention that we give, not just, for example, for your hip or your heart, but actually as a whole.
Yeah.
And I think that's why the data is just so important, isn't it? You know, that when you talk about the uncertainty, and whilst you can't necessarily make that change for all, I think once we're really reviewing data at an aggregate level, we can start to think about what that accurate diagnosis looks like for 80, you know, if we take the Pareto for 80-20, but it is ultimately, as Sarah says, all about what matters to that patient.
So long as we're catching the data of the patients who don't quite fulfill the diagnosis, and we don't, because we're so good at going, all right, back pain, we'll just focus on inflammatory back pain and not deal with anybody else. And in which case, then we've lost the population. The population of those with back pain, they don't come with inflammatory pain, they come with back pain. And so we then select, but then we leave this whole other group that we don't manage effectively. And so we have to capture that data too.
Yeah, if I can respond just to that piece, sorry. So what's been interesting, I mean, through the work, if you compare the work that we've done in the 5 areas to the palliative care work, which is a much more holistic approach, and what we're finding in each of these areas, they overlap. So when we're looking at bone health as an example, the impact of diabetes on bone health, or the impact of bone health on diabetes. So it's starting to make us think about, as you rightly say, the diseases are not linear because they are complex, there's multiple comorbidities, and at some point we're going to have to think about common areas across multiple diseases, and prevention is one that's jumping out to us, that if we can prevent a number of things like smoking, obesity, it impacts on so many other clinical pathways. So what we don't want to do is treat them in isolation and try and fix it for diabetes or bone health. Hopefully that makes sense, Nick.
It does. And so, yeah, it's then finding what are the common outcomes across the whole population and focusing on that. Yeah.
So thanks for that, Adele and Sarah. So we talked about data for quite a bit now, and I'm keen to just talk about a slightly different aspect of value and pathways. I'm really keen to hear from you both about the practicalities of your work when you try to bring stakeholders from across the whole health system to introduce a pathway for something like heart failure or diabetes. And I'm really interested in the nuts and bolts of change, not just establishing a gold standard or not imagining what good looks like, but how do you actually bring everybody together and get people to agree on a way forward with these things and so you achieve a good pathway delivering value for patients, but also that nurses, managers, allied health professionals, doctors feel engaged and that they've contributed. So what's your experience been like in trying to develop these whole system pathways?
So perhaps I can ask Sarah to give you some real examples of the 5 areas, and then maybe I can give you a bit more of a strategic response around how I think it feels. So if that would be okay. Thanks, Sarah.
Right.
I think life generally is about relationships, isn't it? So first of all, you have to build a relationship. You have to understand each other's roles. You have to understand each other's expertise, if you want. And as I said, in some of these clinical areas, we were lucky to have worked with our stakeholders, as you refer to them, for a number of years. So if you want, it was a fairly easy negotiation. In other areas, it was around bringing people together, and that's a slightly different skill. But again, some of it is around understanding where those people are, because we are a small nation, but equally quite fractured. So sometimes it's around understanding who are the key players that you need to engage and bring on board. And bringing consensus is negotiation, isn't it? So as long as you can get people together towards a single aim, and improving outcome is something that's very difficult for anybody to argue against. So I think as long as you can bring people together and kind of understand where they're coming from, why they are expressing, for example, the concern that they are expressing, and how that fit everybody else's need. And I guess this is kind of, if you want, what my job is trying to find that common thread across all of them to bring them together. And I always think that my job is almost like a fixer, if you want, is finding that commonalities and those bringing people together.
And so that's a skill set you've identified. What do those people look like, the people with that skill set to get in a room with experts and non-experts and maybe patients and bring it all together? Is that in the improvement practitioner skill set? Is it project management? Is it just you're born with it and that's a skill you have? I don't know. What do those people look like?
I think the generalist, they have a little bit of everything, jack of all trades and masters of none. You need to know a bit about service improvement, person-centered care, a little bit about digital, a little bit about data. And that's something that nobody's born with. You need experience, you need to grow the next generation of people as well. Is around exposing people to different environment, different challenges, and developing our staff. But a little bit like in health, I think you need that generalist approach.
Yeah. So I'm really pleased to hear that, because if you told me, well, actually, there's only like 3 people in the country who really have what it takes to get this work underway, I'd be wondering how on earth we could scale up pathways. Yeah. But because of my experience, people like that, there are people like that in most systems. There are the people who just are really good at getting in that space and bringing people together and holding people who maybe have fixed opinions at the start and engaging them. So I'm really interested in that. Yeah, thanks, Sarah. And I know, Adele, you wanted to come in on the strategic piece.
I did, but maybe just to respond to that, Dave, I think something, obviously, when you ask somebody like Sarah, what are the skills? I mean, she's going to be pretty shy in talking about some of the things that she has, but I think there's probably 4 things that I would say that anybody that's really good at that has. So they're really, really good at listening, yeah. They're very passionate and enthusiastic around what it is they're doing, but they're very curious. And I think, we must not lose our curiosity so that we want to learn. We're quite happy to say we don't know, those kinds of things. So I think, they're skills that people need. Going back to the more strategic view around this, I think something that's helped us more latterly in the last couple of months has been very much the creation of the executive and the formation of the new clinical networks, and the fact that clinicians have been brought together naturally under that with a very clear purpose and vision around each of those areas. Whereas potentially in the past, Sarah and I have experience of working with a fantastic single clinician who sometimes has to work very hard to get other clinical colleagues on board. I think because the networks have now developed their plans jointly, the discussion and the negotiation between them might have already gone on before we reach them, so there is a consensus around what their ambition is. I think that's definitely helped us, and I think the bit of work that we are doing is probably the easy bit. The hard piece is going to be implementation, and how do we stay in there for the long haul, not just create these pathways, create the measures and then walk away. So it's how do we support the nurses and other clinical teams on the ground to make sure that we're removing some of the barriers for them locally to help address some of this.
Oh, thanks, Adele. Adele, we can hear you perfectly. We can't see you moving, but now we get your back. It could be disconnection on our side. So
Yeah.
There's a couple of questions coming through from people in the audience. So Sarah Lawrence from Betsy asked about data from primary care. And I know we talked about sort of silos of data and work underway. Sarah, is that part of the work underway to try and find ways to utilize data in primary care, or is that a big challenge?
I think there are different. It is definitely an issue if you want that access to primary care, sort of that particularly when you're looking at the full pathway, we do have a very blind spot for what happens in primary, but also community care. I think there is the conversation, I believe, at policy level around trying to unlock some of this data and making it easier for all of us to share and to collaborate around this. But I think there is an immediate risk, I think, and many of you would be aware with Audit Plus, obviously, been discontinued in Wales. So even the little data that we have at the moment at aggregated level for our disease registries, for example, we are possibly going to lose that as well. So at the moment, I think there's a lot of people in the system that have a lot of pressure to try and find ways to even maintain what we have for primary care access of data. So I think I'm hoping that is going to be a bit of a crisis that actually brings better results in the long term. You know, we should make better use of crisis generally, and I think Audit Plus possibly will be hopefully unlocking more in the future. But at the moment, I think the pressure is to try and keep what we have.
I think what's exciting about what you're presenting is it's not a perfect system, and you guys are holding all of this new information, this new way of working. You're recording and having to adapt to the fact that we've got read codes in primary care, we've got ICD-11, we've got the introduction of SNOMED, you know, and that's just coding. That's, you know, that's just such a small bit, but you're, you know, the way you're talking, you're holding that information and then can share that. So at least, you know, in Wales that we have through the Value in Health team, we've got that, you know, that concept of learning. And then can we, you know, I think some of the questions here about where do we learn, how do we learn from others? And is that something that we should explore in this podcast? I mean, certainly there's the mention of GIRFT and whether we should be using more GIRFT. I know there's an element of fear around that. It's certainly in terms of pediatrics, that's what I've heard. And then are there other areas that we are learning from about these particular issues that you've been raising?
Yeah, so maybe if I start with the GIRFT question, Nick. So I mean, hip and knees in particular, we did take the decision that we would include GIRFT into the value metrics purposely, either to dismiss them and recognise that Wales is doing something already. And for example, in the hip and knee arthroplasty, some of the GIRFT measures are slightly outside what we do in Wales. But at least what we've been able to do is to drag the data through and build the evidence to show how we're performing against GIRFT. So we have taken those where they're relevant. I think learning from some of the other areas, what we're keen to do for all of the diseases that we work in is to get the evidence review from NICE and also to talk to our colleagues in some of the UK nations around what we're doing and what evidence they've been able to bring forward. So one of the new areas that we're going to be working on or just about to start is in children's I say CAMHS, it's easier, in mental health. And what we're doing on that is working collectively with Public Health Wales to do a needs assessment and analysis, and then do a full evaluation review of what's already out there. Because even though we've got CAMHS across Wales and I've had it for many, many years, the variation, coming back to Dave's point, is really, really significant. And we know that in Scotland that they've done a huge piece of work around redesigning CAMHS. So again, we're working with the Scottish colleagues to understand what that might look like.
Fantastic. And so it's a sort of a gift of its own, really. It's, yeah.
So again, scanning down the questions here, a lovely question. I love an anonymous question, but we got a question from one of the people who anonymously, probably unintentionally. So blockers within the system. So how can we approach this? Is it due to people not fully understanding the value approach? Is it because the value approach conflicts with a traditional model of improving care? So blockers. What do we do? What is a blocker, and how do you recognize it?
There's a couple of things for me in terms of interpretation of that. So there's either blockers to implement what we're suggesting, which I'll park for a second, or blockers or anti a value-based healthcare approach. So if I take the first one, I think there's many connotations, as you know, of value-based healthcare, and sometimes it can be sold as a new sexy great thing. I think once the narrative is right, dependent, and you can tweak that depending on who you speak to. I'm yet to find anybody that would want to block that approach. I think, they say, value-based healthcare is a new principle, it's a brand new thing again. But when you explain what it's trying to achieve, I'm yet to see anybody that would want to block that. Blockers in terms of how do we make this happen, the so what of us producing this methodology and the optimum pathways. Most often when you talk to colleagues, their common theme will be funding or resources to be able to do this. And I came off a meeting just before this, actually, which is talking about, well, actually, is there sufficient funding in the system? And this is very much a case of looking at the areas that we should be disinvesting in and stopping to release capacity and funds to do the right things. And if these high value pathways are the right things, then we should be working collectively with health boards to look at areas in that space for disinvestment that are not showing improved outcomes or, are not as efficient or productive as they should be. I don't know what you think, Sarah.
I completely agree. I think there's an element of some blockers are system blockers, and we see. I mean, we're very fortunate. We span across multiple networks, multiple health boards. We see that kind of aerial view, if you want, of the system, and a lot of the problems that keep popping up are often the same. And it's something that we've already discussed. Is around data. It's around digital, it's around collaboration, and those are something that I think the system as a whole needs to invest and actually really focus their attention, because it could be something that we can all then benefit, but they're not easy. That's why they're there. It takes a concerted effort to actually go after some of these issues.
I mean, so I think dropping some of the low value pathways can be very difficult, because there will be clinical teams who are absolutely hooked into it. That's what they do. So how do you turn around to them when they say, well, we've got these patients and they've done all right, to look at the whole? And so I know that there's methodologies. I think there's the STAR method.
Yeah.
I think is that Nuffield or
Oxford,
Health Foundation.
Yeah, Oxford, yeah.
And so there are these other methodologies that can be applied in those sort of things, just to sort of help unblock and look at value. Are there other examples of that?
I honestly come back to the use of PROMs and other outcome data. And I think, once we start to show some of that evidence, then, they do become obvious. obvious doesn't mean natural implementation. I appreciate that, because we work in an age-old historical legacy system and trying to make, transformational change. That doesn't come easy. But again, I heard an example earlier today where we're talking about employing clinical pharmacists to prescribe SGLT2 inhibitors, and the impact that's having for diabetes and renal patients. And yet most of our organisations in Cross Wales are not doing that. And the benefits, not just in terms of cost benefit and benefit to patients, is really obvious. So how do we make sure that we are getting to the right people, whether that be policy, whether that be senior directors, around making that shift and supporting clinicians in able to do that?
A really good example.
So a slightly different question. We're really putting you guys through your paces today, so it feels like we're interviewing you and value is on the line. But so we talked a lot about pathways and a big system. We're really talking population health, aren't we, when we're looking at these types of pathways? But what about the slightly more micro view, and so for example, or macro view? Lisa Chichester, who works in Public Health Wales, has highlighted that some services are quite sort of reactive or demand focused, and whilst you can introduce an all Wales or a whole system standardized pathway, it can be difficult to capture the impact on patients. So what if you've got a service like microbiology, which is really in the middle of the health system and impacting so many parts of the population? But how can a team or a service like microbiology measure the impact of pathways? I don't know, Sarah and Adele, is that something you've come across in your work?
One of the things that we've been doing for heart failure, for example, is looking at that early diagnosis. And there is a test called the BNP test that you could do very cheaply. I think it's something like £9. And the idea of a pathway would be that a GP does the BNP, check the results, it's within certain ranges, and then triggers a referral into cardiology with an echo first, an echo being £200-300 a pot. So again, you would avoid releasing value by reducing the number of unnecessary echo. But one of the things we're trying to look at through that heart failure pathway work has been, well, how does that work across Wales? We know that that's what we should be doing. We know that some areas is working well, some areas not working well. So our GPs using that approach, and so we looked at what we could around that sort of from first appointment, if you want, looking back at BNP. And one of the things that we're trying to look is, where is the delay? Is the delay in GP referring onwards? Is it the delay in accepting that referral, or is it the delay in that actual reporting of the BNP and then actually triggering the onwards diagnosis? So again, the data is there to break things down to quite a low level if we need to. It's just understanding what clinical question we're asking.
Yeah, I think the other point, very specifically, if we were to take microbiology as an example, the way that we've been able to overcome that in the past is if we combine our work, which we do with the Finance, Performance and Delivery Directorate, and we use time-driven activity-based costing. So we have a look at every step in the process, and in particular the cost to microbiology and so on. The challenge, as you rightly infer, David, is how do you really evidence that benefit? And something that we struggle with all of the time is, what's an opportunity cost versus what's a cash benefit, what's cash releasing? And I think a lot of those things in microbiology, unless you're going to change the test to something that's a reduced cost, then you're talking about opportunity costs around productivity and efficiency. And that is very difficult to evidence, other than unless it affects a bed day, we don't really see those kinds of things. The measure is about how many bed days have gone. So it is an extremely difficult one.
Yeah, and I don't have an answer for that necessarily either, but it does highlight a problem when you do something which is not so easily measurable, or maybe feels a little bit remote to the patient. How do you bring value to that? Because value must have a role in microbiology. It must. I can't believe
Yeah.
it doesn't. But
Yeah.
if you got teams in microbiology or other parts of the system, you know, what are the aspects of value that we can bring to those teams?
Yeah, so a colleague of mine, if there are, I'm conscious of time, so, but if people are listening today and they're really keen to pursue the work around microbiology, one of our other colleagues in the team, he's David Hayburn. He's currently doing a lot of work in this space, looking at point of care testing and looking at other aspects of the microbiology process to think about how can we add value, in particular, you know, stopping tests when they're not adding any value, making sure that we are taking the right blood test. So not for the detail today, but again, if people wanted to learn more around how you'd evidence value in microbiology, we could definitely support some of that.
And so what you talk to there is patient experience, because patients don't want to have a test that's then redundant.
Correct.
And a lot of that happens, and we know there's
Yeah.
a lot of redundancy in the system. So
Maybe that's it.
So patient experience rather than just outcome, and I think that's critical. So I mean, we've covered a huge amount of area on this. So just a very quick one to end on. What sort of light bulb moments have you had in the last year or two when you go, a crystallized thought in value that you would want to share? I know I'm just throwing that out there.
Yeah. Gosh, that's a difficult one. I'm not a reflector, actually. I normally jump with 2 feet in and then get myself caught out. So this has really flown me a little bit. I think for me is it's still, maybe this isn't directly answering, but it's still as obvious today to me as it was 10 years ago when I first met Dr. Sally Lewis and she tried to explain value-based healthcare to me. My response then was, isn't this happening? Isn't it just common sense? And why aren't we doing it? And I still find myself today uncovering things. So it's not a light bulb moment, but it is a switch that keeps going off saying, this is still common sense, but we are still doing the things that are not adding value to our patients and the system.
Yes.
Sounds like a klaxon. And Sarah, anything that you in your experience, any penny drop moments or things that just lit up for you or in the work at Value?
I think particularly with the value measures that what we've been doing, to me is the potential of the NHS executive. I think is not there yet, but I think the fact that we now have these buffer, if you want, between policy and implementation and the ability to look across different enablers, different conditions, look in population health. I think the potentials there are massive, and we really need to make sure that we utilize that to the best. And as I said, it's very new. It's going to take a while, but I think it's quite exciting time.
Yes.
I mean, for me, I don't know about you, Nick, but for me, reflecting on today's session, I'm going to reclassify blockers into critical friends. So I think probably there's everybody who comes across maybe as a blocker is actually somebody who's seeing things from a slightly different angle to you. And, you need to put yourself in their shoes and try and understand that perspective, I think, to work it through.
And honing the generalist. We forget the generalist. We always think these days we become more and more silo, but actually the generalist that you described there really well, Sarah, in bringing people together and not, the jack of all trades. And I don't think we celebrate them enough. And I think that's to be applauded. So thank you.
Okay, well, Adele and Sarah, thanks so much for joining us today. It's been an absolute pleasure. And to everybody who joined us from across Wales and beyond, thank you so much for joining us, and we'll see you again soon.
Thank you.
Thank you very much.
Thank you.
Thanks.
Bye.
Thanks.